Dr. Kate Martin. Kate is a general and trauma surgeon at the Royal Melbourne and Austin Hospitals in Melbourne, Australia. She is a director with the EMST and DSTC faculties and is a past supervisor of the General Surgical Training Program at the Alfred. Kate is the Vice President of ANZAST and the immediate past chair of the EMST committee. She is also a member of the Federal and Victorian State Trauma Committee of RACS, as well as the DSTC committee. Kate is a member of the RACS Academy of Surgical Educators with an active interest in surgical and trauma education. As part of the GSA ANZAST trauma training committees, Kate has been involved in establishing the PFEFT program in trauma, a program for fellows of the Royal Academy of the College of Surgeons. Ladies and gentlemen, Dr. Kate Martin.
Thank you.
Hello from Melbourne, Australia. My name is Kate Martin and I'm a general and trauma surgeon at the Royal Melbourne Hospital and Austin Hospitals here in Victoria. I'd like to say a big thank you to Ning Turk and Rolando for inviting me to present today as part of the Asian Collaboration for Trauma webinar series. I will start by acknowledging the traditional owners of the land on which I meet here in Melbourne, Victoria, Australia, they being the Wurundjeri people. They acknowledge their leaders past, present and emerging. My topic today is damage control resuscitation. I think this is an important topic because hemorrhage remains the most common cause of preventable morbidity and mortality trauma. Over the next 20 minutes or so, I hope to cover the definition of damage control resuscitation, spend a bit of time reflecting on the pathophysiology of hypovolemic shock, and then focusing on the core components of damage control resuscitation, they being restoring and maintaining critical perfusion, managing coagulopathy, and surgical decision-making. Damage control was established as a rescue technique by the Navy with the aim to prevent the sinking or breakup of a ship after catastrophic injury. Similarly, in trauma surgery, damage control is defined by a set of manoeuvres used to reverse that pre-terminal effect of massive exsanguination, injury and shock. It really is a directed resuscitation and involving staged surgery to allow for the resuscitation and restoration of normal physiology. Optimal management of the bleeding patient is now termed damage control resuscitation, and it's a critical adjunct to damage control surgery. In fact, many of us now consider damage control surgery a part of the continuum of damage control resuscitation. Other components of damage control resuscitation include anticipating and treating coagulopathy, hypothermia and acidosis. It involves the control of bleeding, the control of contamination, temporary wound closure, particularly in the case of laparotomy, and restoration of normal physiology, including coagulopathy. This then results in a delayed definitive management of any of the injuries identified. The shock results in cellular hypoperfusion, and we do aim to look after the patient primarily at a cellular level. Cellular hypoperfusion deprives deprives the cells of oxygen and other essential substrates. This is then compensated by an upregulation of anaerobic metabolism, resulting in the formation of lactate, and when prolonged, results in inadequate generation of ATP. This then leads to the loss of cell membrane integrity, resulting in a loss of the membrane gradient across the cell membrane and the release of pro-inflammatory mediators. This then results in progressive cellular damage, resulting in increased tissue permeability, edema, impaired receptor function, and eventually irreversible cell injury and organ failure. Ultimately, this means we want to resuscitate the patient to maintain oxygen delivery at a cellular level. Otherwise, the patient will progress to an irreversible cell damage, multi-organ failure and death. And this is essentially the progression of the systemic inflammatory response that we see in severe trauma. Now, I don't need to preach to this audience that shock in trauma is most commonly due to hemorrhage. However, it is important to consider other causes of shock, as this has relevance to our management of these patients. And this is borne out in our approach to the way we treat patients who arrive in traumatic cardiac arrest, which really does address multiple causes of arrest, including the main causes of shock being hemorrhage, tension pneumothorax, and less so tamponade. In response to blood loss or volume loss, the physiology results in vasoconstriction to increase total peripheral resistance. This is both at a cutaneous level, but also at a visceral level as well, and will initially result in an increase in diastolic pressure and a reduction in pressure. Increased heart rate also aids in preserving cardiac output, as does increased cardiac contractility to preserve stroke volume. Contraction of the venous volume that does not contribute to the mean systemic venous pressure, that is that venous capacitance that we all have, helps to preserve venous return. However, this is limited, and in the situation of major volume loss, that is class 3 or 4 shock, this venous return quickly begins to decrease. These physiological changes are mediated, as you're aware, by a host of functions, including catecholamines and other hormonal factors, inflammatory mediators, as well as the autonomic and somatic nervous system. Suffice to say, the most effective method to restoring cardiac output is to restore venous return, that is, restore volume, but also concurrently stopping the bleeding. I'll now spend some time reviewing the key priorities of damage control resuscitation. Using the principles established by ATLS with rapid diagnosis and simultaneous treatment of immediate threats to life, damage control resuscitation occurs within the context of the primary survey, which I'm sure you're all familiar with. While this talk focuses primarily on the bleeding patient, it is important to consider the other immediate threats to life that so many of our patients have, and to ensure that we do treat these early on in that initial assessment. Hemorrhage control also, in many circumstances, will begin prior to the patient arriving in hospital and may include compression or direct pressure with tourniquets, pelvic binders, the splinting of long bone fractures, and in some circumstances where resources allow the infusion of packed red cells and other blood products. The 3 key priorities in damage control resuscitation are: 1, to restore and maintain critical perfusion; 2, to manage coagulopathy; and 3, ensure early decision making to result in definitive control in bleeding. Shock may be multifactorial or also, as I've alluded to, and I think it's worthwhile considering that much of the diagnoses we make as clinicians is based on simple examination and bedside testing. And this includes clinical examination, assessment vital signs, and simple tests, including blood pressure, response to volume resuscitation, and if possible, blood gas analysis. It's also important to consider the dynamic situation and appreciate that shock evolves over time. Physiological parameters will change in response to resuscitation, and it's worth taking a moment to consider what has happened in the pre-hospital setting as well as on arrival. I often ask myself, is my patient a responder or a non-responder or a transient responder? Because it very much helps me in my decision-making with this patient. The key question is the patient still bleeding? And if so, where are they bleeding from? Because the patient who is still bleeding requires damage control resuscitation and some form of definitive control of that bleeding. In 2007, John Holcomb, a prolific author in the field of volume resuscitation in trauma, challenged the standard crystalloid-based resuscitation we were also familiar with at the time. This work was born from his experience in the military and then translated into the civilian population, and really did go a long way to establishing the role of delivering packed red blood cells, pressure frozen plasma platelets, and other blood components in such a way so as to not only restore volume and oxygen delivery, but also to concurrently correct and maintain appropriate coagulation. It was specifically a higher plasma to red blood cell ratio that was found to be associated with improved survival, particularly in this military population. Further evidence as to the benefit of fixed ratios of blood products was borne out in civilian studies, and the delivery of fixed ratios of blood products has now been established in the form of massive transfusion protocols across the world. The East Guidelines, which were published in 2017, outline the evidence available at that time in regard to the role of massive transfusion protocol and the components that should be considered. And this really has now become a standard form of care in trauma resuscitation, and particularly important in damage control resuscitation. Now, as we continue to resuscitate our patients, particularly with blood products, we do need to consider our targets and our endpoints. I think it's really important to have frequent reassessment, particularly in relation to the physiological response that the patient displays, but also to the biochemical evidence of ongoing hypoperfusion or correction thereof. And I like to use blood gas analysis for this. If available, laboratory evidence of coagulopathy or its correction is also invaluable, and we use either ROTEM or TEG, but some of the more traditional tests such as INR and APTT, fibrinogen levels, platelet levels are also important if you have access to them. I think what's also important, particularly for those institutions where the massive transfusion protocol initiates the delivery of a box of products, is that treatment should be tailored to the needs of the patient and not necessarily dictated by what comes in the box. This is particularly important if it appears that the patient has a coagulopathy where the early infusion of FFP, cryoprecipitate, platelets and TXA could be quite beneficial. I have listed some of the endpoints and exit criteria there. This is a guide only. Obviously, patients are a heterogeneous group, and particularly with regards to systolic blood pressure, whilst we do aim for at least a systolic of 80 to 90, in the patient with an obvious traumatic brain injury, we would be aiming for something higher. And I would suggest in our elderly population, we should be aiming for slightly higher systolic pressure as well, probably something in the order of 100 millimeters of mercury. Another important component of damage control resuscitation is restrictive volume resuscitation, otherwise known as permissive hypotension. And this study really was one of the earliest to show that, that it really did improve the outcome in patients, in particular mortality from early blood loss. The aims of permissive hypertension is really to minimise additional blood loss and give clot some time to form. The term "don't blow the clot" is often used, but my experience is you often don't get the blood pressure up quite high enough to literally blow a clot off, but at least giving the opportunity to get that patient to definitive control of bleeding. How low can you go? As I suggested, brain injury patients probably need a MAP of greater than 80 millimeters of mercury. So you're looking at least a systolic in the triple figures of 100 or so. But in the absence of a suspected brain injury, so for example, penetrating truncal trauma, certainly in a fit, healthy adult, a systolic pressure of 80 should be well tolerated for a short period of time. The second really important concept of damage control resuscitation is the management of coagulopathy. And no doubt you are all aware of the landmark study published by Crimbroe and his team back in 2003, which is really the first to document the concept of the acute traumatic coagulopathy. He was able to show that intrinsically 25% of his severely injured civilian trauma patients arriving at a level 1 trauma hospital had established coagulopathy, having had none of the other interventions that would contribute to that, such as fluid administration to dilute clotting factors, hypothermia, or even established acidosis at that stage. The incidence of coagulopathy does increase with the severity of traumas, and we do know that coagulopathy patients with the same severity score do have are more likely to die. So this is why it isn't. Acute traumatic coagulopathy is only one part of the broader condition commonly referred to as trauma-induced coagulopathy. While the spectrum of coagulation dysfunction in trauma ranges from hypocoagulability to hypercoagulability, it's the former that usually predominates early in acute hemorrhage. Acute traumatic coagulopathy, as described by Karim Brohi, is an endogenous component of the broader trauma-induced coagulopathy, and it does include hyperfibrinolysis, which we treat with TXA. But this acute traumatic coagulopathy is augmented by factors such as dilution, hypothermia, and acidosis, and this all then contributes to the trauma-induced coagulopathy, which we are all familiar with. In order to effectively treat coagulopathy as well as prevent coagulopathy occurring, we need to address all components, and that means addressing hyperfibrinolysis through the administration of TXA and fibrinogen concentrate when required, attention to the packed red cells, FFP platelet ratio, and administration of calcium, minimising, and I would actually suggest eliminating the use of crystalloids, and warming the patient and all fluids that are administered. It's also important to really early on make efforts to restore perfusion of oxygenated blood, and this is going to involve definitively controlling the bleeding that's ongoing. Much of early surgical decision making is really important in trauma, which is, I guess, pretty obvious, particularly to the audience that we have here. Once the diagnosis of ongoing bleeding is made, however, all efforts must be made to stop it. Every additional 3 minutes of bleeding, we think, still contributes to approximately a 1% increase in mortality. Now, having said that, decision making in trauma is based on probabilities more often than certainties. And this is where it is very different to our other practice of elective surgery, where we have a diagnosis, we have the anatomy. In trauma, we have the physiology and we have the anatomy of the injury, but we don't necessarily have all the diagnoses. With this in mind, we essentially have two tools at our disposal in most centres, acknowledging that not all centres will have access to embolisation, but generally speaking, we have two approaches that we can use. The first and the most commonly used is operative intervention, and this allows us to continue damage control resuscitation within the operating room and adding to it that damage control surgery, whether it's a laparotomy, a thoracotomy, maybe pelvic packing, an application of an external fixator or an external fixator to a broken limb. Where available though, embolisation also does give us the opportunity to control bleeding quickly and efficiently, particularly in those hard to reach anatomical locations. Irrespective of what resources you have available though in your centre, there does need to be some system to allow for rapid transfer of the patient to, whether it's the theatre or the angio suite or the hybrid suite if you're very lucky, to continue the resuscitation and also to control the bleeding. So even if it is simply just to the operating room, having a system in place to allow the rapid transfer of that patient once it's acknowledged that they are continuing to bleed is really important. So what do we do with damage control surgery? What's the decision making? Well, the decision making is really dictated by into the operating room. You know, unless things turn very quickly, you know you're going to be doing a damage control approach for those patients because the physiology is severely deranged. Sometimes the physiology becomes more deranged whilst in theatre, and that may be a time then to turn to damage control too, particularly if coagulopathy has become an issue. But there are additional indications for damage control surgery other than disturbed physiology. And here are some of the common ones that I've come across in my practice. Often you'll have patients with multi-system trauma and there may be competing management priorities. And the classic example of this is the patient who has the blown pupil with a traumatic brain injury, but also has intra-abdominal bleeding. So for these patients, we're going to quickly control the bleeding, whether it's removing the spleen or controlling the hollow viscous bleeding. And we're going to do packing and temporary abdominal closure so the neurosurgeons can get on and decompress the subdural or the extradural. You may have a pattern of injury that necessitates damage control surgery also, and it's really the major vascular injuries that necessitate this, particularly when there's multiple hollow viscous injuries associated with that. Some injuries are complex and may require a staged approach, and this is particularly the case with duodenal and pancreatic injuries. There may be a requirement for an endovascular management of some injuries. So, for example, the patient who has quite a severely injured pelvis, who you may, and a positive fast, you may take them to theatre, deal with the intra-abdominal bleeding in a damage control way. You may leave the pelvic binder on or put an external fixator on, but then move to the angio suite to control pelvic bleeding because you've seen a large pelvic hematoma there. And then finally, the need for transfer or some form of specialist involvement. Many of our patients are initially managed in non-major trauma centres, and these centres are vital for the initial stabilisation of patients. However, in the situation where there are complex injury, and I will use the example of duodenal and pancreatic injuries again, that would be an example of having that patient transferred to a specialist centre. So you're going to do the bare minimum. You're going to control bleeding, control contamination, and have some form of temporary wound closure. So in summary, timely decision-making is vital, and the role of the surgeons begins with resuscitation in the resuscitation room. Volume resuscitation, with the early use of blood products, along with the minimal use of crystalloid to prevent the dilution of clotting factors, is vital. Volume restriction can help maintain critical perfusion while limiting excessive bleeding until you have definitive control of that bleeding. Is important, as too is the treatment prevention of hypothermia and the restoring perfused oxygenated blood. It's important to frequently reassess patients and rapidly transfer them to a part of your hospital or to a centre where definitive control of bleeding can be obtained. So with that, I'd like to again have a big thank you for the opportunity to present to you today. I'd also like to acknowledge...
So the reactor for Dr. Kate would be Professor Jae-Gil Lee of the Division of Acute Care Surgery of the Department of Surgery, Yonsei University College of Medicine. He obtained his bachelor's degree in the Yonsei University College of Medicine, Seoul in 1996, and he obtained his master's degree of medicine from the same institution in 2006. He obtained his PhD degree of medicine from the Korea University College of Medicine in Seoul in 2008. He obtained his residency in the Severance Hospital, Department of Surgery, Yonsei University College of Medicine. He had his clinical fellowship at the same institution, Division of Hepatobiliary Pancreatic Surgery, Department of Surgery. He was assistant professor in the Division of Surgical Critical Care and Trauma, Department of Surgery, Yonsei University College of Medicine. He was associate professor, chief of the Acute Care Surgery, Department of Surgery, Yonsei University College of Medicine, and is presently a professor, the chief of the Acute Care Surgery, Department of Surgery, Yonsei University College of Medicine, Seoul, Korea. He has obtained his Korean Board of General Surgery in 2001 and subspecialty of Critical Care Medicine in 2008. Ladies and gentlemen, Professor Lee.
Good evening, everyone. Thank you very much. And thank you very much for your nice, kind introduction. My name is Jae-Gil Lee. I'm an acute care surgeon in Yonsei University College of Medicine. So it's a great honor to be a reactor of this wonderful webinar, and thanks to all committee members for ASEAN collaboration trauma, especially Professor Chu and Ronaldo. Furthermore, thank you for your Dr. Kate Martin for your great lecture about damage control resuscitation. As you know, usually the damage control surgery is widely accepted in trauma and now non-traumatic emergency surgery field after introduced by the at 1980. Damage control surgery is just focused on the surgical strategy and post-operative critical care to control the coagulopathy, hypothermia, and acidosis to prevent the ongoing bleeding. Many trials and studies are revealed the pre-operative and immediate injury coagulopathy induced by trauma is related to poor outcome after bleeding control surgery. So pre-operative and early correction and prevention of trauma-induced coagulopathy is very important to achieve the optimal goal in traumatized patient. These results showed and introduced by the Kate balanced transfusion of PEG RBC, frozen plasma, and platelet, early detection of coagulopathy using TAG or ROTEM, and early use of antifibrinolytic agents. So the DCR is the concept of expanded damage control surgery, including pre-operative optimization of or control of coagulopathy. I think the damage control resuscitation is composed by three components. First, permissible hypotension, limited fluid infusion less than 1 liter initially, and minimize the volume therapy, and maintain the systolic blood pressure less than 90 millimeter mercury, and early use of vasopressor in sometimes to maintain the optimal SBPA. However, the duration of permissible hypotension is not definite. As you know, usually is associated with golden time. Golden time is usually accepted with 1 hour after injury. However, there is no definite duration. Some experimental study using rat and show the less than 19 to 112 minutes is optimal. Second is hemostatic resuscitation to prevent the coagulopathy. Early detection of or suspicion is very important to prevent the coagulopathy. So usually focused on the, we have to focus on the sign of bleeding or coagulopathy or any bleeding process. Our massive transfusion protocol using optimal ratio of PEG RBC and plasma and platelet, and warming to prevent hypothermia in early stage, and use of tranexamic acid is very important. However, most important is early bleeding control. If the bleeding control is achieved in optimally, the damage control resuscitation is not helpful to the patient outcome, for patient outcome. So this, so we have to just focus on how to control the bleeding in early stage. And third is damage control surgery. So if the patient are unstable or deteriorates during the bleeding control surgery, packing of surgical gauze or control of contamination and temporary closure of the abdomen is performed. I just keep in mind the concept of this damage control resuscitation in traumatized patient. However, some patients did not show any evidence of the bleeding despite of their hemodynamic instability. We cannot find any bleeding sign or by FAST or CT scan, especially in multiple trauma patient, especially in blunt traumatized patient. In Korea, pull down or outpatient, outpatient pedestrian injury is most common in blunt type injury. So at that time, we have just missed the coagulopathy or other thing because of their hemodynamic status rapidly deteriorated. So they usually show the hemotherapy stability in early period. So when we perform the initial diagnosis, they rapidly deteriorate. At that time, we just miss and we cannot perform the damage control resuscitation. So I learned the damage control resuscitation is just extended form of DCS, but in now, recently, most injured patients not require surgical treatment. They are, as you know, the embolization or other bleeding control strategy may used to control the bleeding, but the bleeding control intervention is not rapidly or optimally adopted in the patient. We can lose it. So we just, I think we keep in mind the optimal treatment to stop the bleeding. I have one question to Dr. Kate Martin. Actually, as you know, in damage control surgery is introduced in penetrating injuries such as gunshot. But in now, I'm not sure that your country is how many patients are injured by the gunshot or penetrating. But in Korea, most 95% is injured by the car accident or fall down. So in that time, damage control surgery or resuscitation is very difficult to adopt in early period in the patient. And now my institution is not dedicated to trauma center, and just only one trauma surgeon is working in this town. So I cannot access easily to the patient because, but in that time, how can you adapt your the damage control surgery resuscitation in blunt traumatized patient?
Thank you very much for the question. So just to, I guess, recap, most of the question is, how do we adapt damage control resuscitation, which includes surgery, to blunt trauma? So as you correctly pointed out, the majority of our trauma is in fact blunt trauma, predominantly motor vehicle accidents, but also falls is also a close second. About 6% of our trauma at the Royal Melbourne, where I work, the level 1 trauma service where I work, is penetrating. Having said that, the majority of our patients that we do damage controlling will still be blunt trauma because of the sheer numbers. We have about 1,200 severely injured or major trauma patients per year. A lot of our patients do have to travel quite some distance, even within the state of Victoria. So it's usually at least an hour prior, from the time of accidents before they arrive at our door. So there has been a degree of time for bleeding and therefore physiological derangement to occur. So that would be one indication to it. And then the other indication that we commonly see is patients with competing injuries. So whilst physiological derangement is the classic indicator for pursuing a damage control approach to these patients, equally so, I think, in our institution is when you have multiple injuries, and in particular whether it's intra-abdominal with severe pelvic trauma or with an intracranial injury, so a severe TBI. A lot of our patients will also have multiple areas of injury, so their limbs are injured as well. And that in itself, the sheer volume of soft tissue trauma creates a physiological insult of itself and certainly contributes to the coagulopathy of trauma that I explained. So I think for those three reasons, a lot of bleeding before they arrive because of the distance, competing injuries in multiply injured patients, and a high degree of, a large volume of soft tissue trauma all contribute to the need for damage control in our blunt patients, which is the patients we're most familiar operating on. Certainly penetrating injury. Luckily, it's mostly low velocity. In Australia, we have gun legislation. We don't have a lot of gun deaths. I actually looked at the figures, and only 24 people died from gunshot injury in our whole country last year. Of which most of those were murders, but still there were a lot from suicide. But It's not many. So most of ours are going to be stabbings and low velocity trauma.
Thank you.